Good afternoon, everyone. Welcome to the post-lunch session of the RISHI. The first lecture that was on schedule is not there by Dr. B.Kuppermann. So we have the second lecture on Orcam by Elad Moisseiev.
Thank you very much. I'm very happy to be here, and I would also like to say thank you for the organizing committee. This is my first time in India, and I'm liking it very much, and also this meeting, of course. My talk is not really about imaging, but it's about another important topic, and I guess this was the best place to put it in. So I'm going to talk about the Orcam, which is a new portable artificial vision device for patients with low vision. I have no disclosures and no interest in the company. They just loaned me a few devices for a study I did, which I'd like to present to you. So as we all know, low vision is a major handicap for patients, and it doesn't really matter what made them blind. Once they're there, it's very frustrating for them and also for us as physicians. Sometimes we have nothing good to offer. And for decades, the only solution was just magnifiers. In the past decade or two, this evolved a little bit, and we have scanners now. But these are basically just electronic magnifiers, so not much new there. But in recent years, there are many technological advances, and there's a lot of research focused also on low vision, which is sometimes we as physicians, as treating physicians, don't really do. And these are just two examples of new things that look very high-tech and cutting-edge, not very popular, but this is the direction we're going into. And this is the Orcam device, which I'd like to talk about. It's based on optical character recognition. This is what it looks like. There is a small battery and computer pack that can be attached to the belt or put in the pocket, and a small camera that just attaches to the glasses, and it actually can recognize print, money, faces, and any other object you can program it to know if it's in front of the wearer. And it's activated by a simple gesture, just pointing your finger, and it kind of takes a picture and reads to your ear what is in front of it. It's been developed by Mobileye, which is an Israeli company that's leading the autonomic vehicle industry, by the same two engineers who invented that. Because one of them had an aunt or something like that went blind from AMD, so that led to this development. And of course, this is a source of Israeli pride for us. And then my purpose of the study was to evaluate how effective this can be for patients with low vision. So we took 12 visually impaired people, regardless of the indication, but they were all legally blind. And we developed a 10-item test for just daily routine activities that you need at least medium vision to do. And we just scored 1 or 0 if they could do it or not. And then we let them do it with their basic low vision, any other low vision they had been using before, and using the Orcam after just 1 hour of instruction. This is a busy slide, but it just shows the 10 tasks we asked them to do. These are very simple day-to-day things that patients with low vision cannot do, like read an email, or recognize money, use a menu, or just notice a sign on the wall. And this is just an outline of the patients. Again, very different ages, very different indications, but they were all legally blind. And this is our results. You see that without any help, their mean score was 2.5, meaning most of them could not do almost anything of these basic items. And after using the Orcam just for 1 hour, they could do between 9 to 10, all of them. So it was very easy to understand and very effective in terms of the tests that we designed for them. We let them use it for another week. They didn't have much room to improve, but they all had a good experience, and they could repeat and do it even a little better after 1 week. When we compared how they did with other low vision aids, we saw that the magnifiers and the scanners help. They let them do, on average, about 6 of the 10 tasks. But with the Orcam, of course, it was a lot better. So we concluded it was an effective low vision device, simple to understand, and maybe even better than the classical low vision aids. Later on, the company went on to develop the Orcam version 2, which is much better. There's no longer the battery pack. It's all inside, a very compact design that is attached to the lens. There's no wires. You don't have to hold anything in your hand, and you can put it on both sides of the glasses. The first version was only on the right side, and it was bothersome for some of the patients. And they also included more features. It can recognize anything that has a barcode. So now low vision patients can just take something off the shelf in the supermarket and know what it is. It can recognize more hand gestures. It can tell patients what colors things are in front of them, and also learn more faces. This is what it looks like in large scale, and it's basically just very simple to operate with one kind of touch or slide button to the side, and it can attach to the glasses and very, very effectively. This is just an illustration how a visually impaired person can understand what box he took from the shelf. And this is a short clip of a kid who is reading now. This is a blind child. And he actually doesn't even have to hold the book in front of him. As long as he took one picture, the sound is off, but if the sound was on, you could hear what he's hearing, and it's just the machine reading the text that was in the book in front of him. And the company is growing. They've spread outside of Israel. This is just a map of their distribution. And they're doing it in many languages. Of course, they started in English. They have it in Hebrew, but they also have it in Spanish and several other European languages, and in Japanese and Korean. And I think that in the near future, maybe they will come to India as well. They're getting a lot of interest, as you can see here. This is our Prime Minister and Prince William, who visited Israel last year. So very few companies got to present, and they had the opportunity. And I think it's something that it's good for us as physicians to be aware of, because sometimes this is the only thing you have to recommend to your patients. Thank you very much.
Thank you, Dr. Elad. Thank you, Dr. Elad. We can take one question because we have two people who have dropped out. So anybody would like to direct a question to Dr. Elad?
How much does it cost?
Full price is something around, I think, $3,000. In Israel, there is a 50% subsidized by the government if you're legally blind. It's not expensive, but it's not cheap. I'm sorry. Again, I'm not with the company, but it's not very cheap, but it's a single expenditure.
And it's available on EMIs. That's what you said in the beginning. Where? It's available on EMIs.
EMI
it's available on EMIs.
Yes. Thank you.
Manish?
One second.
This company is already in India, and they have a person based in Mumbai, and actually they had come and met me in my hometown. So if anybody is interested, I can pass on the number.
The guy who is there is in Bombay only, and
yes.
He happens to be a friend of mine.
Oh, yes. Okay.
Great, that's good news.
Could we call upon Dr. Bailey? Oh, he's already over here. You could go ahead with your talk. He's going to speak on speckled hypoautofluorescence as a sign of resolved subretinal hemorrhage.
Okay, I want to thank the organizers again for inviting me to speak, and on behalf of my co-authors, it's my pleasure to present this data. So this is a small imaging point, but I think it's quite clinically valuable. If you were to look at these two eyes, would you be able to say which of these cases of neovascular AMD have had prior subretinal hemorrhage? Do you know, David, which one has had prior subretinal hemorrhage? One? Yes. So what he's noticing is that there's this ring of hypoautofluorescence in the eye on the right, and then on the left, there's hyperautofluorescence. And so that's, I think, a very useful way to distinguish. So let me give a little background here. When we have any of a variety of retinal disorders where we have disruption of the ellipsoid zone and the interdigitation zone, we will see unmasking of the normal RP autofluorescence. So reduced photopigment density because the outer segments are disruptive. And here you can see that zone of hyperautofluorescence. and it corresponds to the disruption of the ellipsoid zone and interdigitation zone, but the RPE is intact. So it's normal, there's a normal fluorescence from the RPE, but we're seeing more of it because there's less of the excitatory light and the emitted light from the lipofuscin getting through to our sensors. So we see a brighter area. And in some cases, such as inflammatory eye disease, syphilis, and other things, that can recover if the ellipsoid zone and interdigitation recovers, as it does in this particular case after the inflammation resolves. David has described this in Muse patients as a good way of seeing the extent of the involvement. In central serous, we also see the same thing. We see it in areas of subretinal fluid. Now, it doesn't distinguish whether the subretinal fluid was there in the past or it's there currently, but you'll see hyperautofluorescence in many cases when there's subretinal fluid and there's disruption of the outer retina. In this particular case, this is permanent loss, and this will persist indefinitely. Here is a case of plaquenil toxicity, where we also early on see loss of the outer retina before the RP is affected. You can see that on the OCT very nicely. And there's these zones of increased hyperautofluorescence related to that, which we can look quantitatively with this technique called quantitative autofluorescence, and it corresponds, if you flip it over upside down, it corresponds to where the field loss is. And then you see the typical finding in the fovea, sometimes referred to as the fovea, the flying saucer sign, where you lose more of the outer retina around the fovea, but not centrally. So I found it very helpful that the CAM group has come up with this classification because it sort of can be applied to other entities besides just AMD. This case of age-related choroidal atrophy is a good example of where you have loss of outer retina but intact RPE, and you don't really see much of a change in autofluorescence. Here's another case with multifocal choroiditis. And here we have permanent loss of outer retinal structures. So you can see when you zoom in on that, that basically where you have loss of outer retina or incomplete outer retinal atrophy, you'll see hyperautofluorescence. But in the area where you've lost both the RPE and the outer retina, this a complete RP and outer retinal atrophy, then you'll see hypo. So loss of outer retina usually produces hyper. So with that background, let me just take you through these cases that we recently published in Retina. So the purpose of this particular study was to look at this pattern and to look what happens over longitudinal follow-up. And we looked at this with all the different autofluorescent devices. So whether it's the shorter wavelength blue autofluorescence, the green autofluorescence, colored autofluorescence, you'll see the same hypoautofluorescent pattern if the blood has affected the outer retina but left the RP intact. These are cases. Most of these patients were on anti-VEGF therapy for neovascular AMD. So here's an example of what we see with subretinal fluid. So here we have persistence of the hyperautofluorescence in the area where we have incomplete outer retinal atrophy, the RPE is intact. So hyper when it's fluid. But here's the pattern when we see resolved hemorrhage. So once the blood is gone, we have this persistent zonal area of hypoautofluorescence. Plus, we see this sometimes a speckled pattern, and I'll show an example of that. So just another case where you can see after the hemorrhage resolves, the OCT shows that the RP is still intact, but the outer retina is gone, and for some reason it's dark rather than bright. So it's the exact opposite of what we see with subretinal fluid. Another case here, again, RP is intact, but the outer retina is significantly atrophic, but it remains hypoautofluorescence, the exact opposite of what we see following resolution of subretinal fluid. And here's a nice case showing this speckled appearance. So many of these patients within the area of hypoautofluorescence will have these clumps of hyperreflective material that sort of thickens the RPE Brux complex on the structural B scans of OCT, and those are particularly hypoautofluorescent, as you can see here. Here's just a really nice example of that pattern. So I use this in clinic every day, and I often challenge my residents, if it's a patient who's had a long history of neovascular AMD, I'll tell them, okay, just look at the autofluorescence and tell me, where has this patient had fluid in the past, where have they had blood in the past? And without knowing any history, it's very easy to tell. So if you see what is shown on the color photo and circle, I mean, that's unmistakable that that patient has had subretinal hemorrhage there, and it's a great example of that speckled hypoautofluorescence. So you can see on just the grayscale autofluorescence how dark it is. This is a technique of color autofluorescence on the right that I think Dr. Sada is going to speak about either at this meeting or the next one. And here's just a nice correlation with structural OCT. So where you see those sort of darker areas of hypoautofluorescence, there you see this clumps of hyperreflective material that sort of thickens the RPE-Brux complex. And this is something that you will see not only in the macular region, but in the periphery, as we see in this patient, which had a very large subretinal hemorrhage from a peripheral exudative hemorrhagic chorioretinopathy. After the blood is cleared, the hypoautofluorescence remains. And it's not limited to AMD. You'll see the same thing in ruptured macroaneurysms or anything that can cause loss, that can produce large hemorrhages. Here is an example of just looking at a patient and being able to recreate the history. You can see that in the temporal macula inferiorly there was subretinal fluid leaving that hyperautofluorescent pattern, but above the patient had a subretinal hemorrhage leaving the autofluorescent pattern dark. Here's another example where this is the first time I've seen this patient who has more peripheral AMD with exudation. And you can immediately tell that inferiorly this patient has had subretinal fluid, where it's hyper, and above there's been prior hemorrhage. And this is just showing the same thing with the color autofluorescence. And we're working on trying to figure out why it has a specific wavelength. Exactly what causes this hypoautofluorescence, it's a bit of a mystery. We're working on a clinical pathologic correlation of a case that has it, and also in collaboration with Penn, we've been looking at potential mechanisms whereby the iron may interact with the lipofuscin inside the cell. This is a case that Giovanni presented at the Academy at the Gas Retina Club, and this is a patient on deferoxamine, an iron chelating agent for iron overload, and it just struck me as how similar this appeared. So maybe this is a clue as to the mechanism of what's causing that hypoautofluorescence. So in conclusion, areas of hypoautofluorescence in the absence of RPE atrophy, they show us where there's been prior subretinal hemorrhage once it's resolved, and this pattern is very distinct from the pattern we see when there's RPE loss, complete RPE and outer retinal atrophy, because there you would have hypertransmission. Here, because the RPE is intact, you have no hypertransmission of the OCT signal into the choroid, and I find it very useful because it's the complete inverse of what we see when there's been subretinal fluid, so it can easily identify where there's been hemorrhage and fluid. So thank you for your attention.
Thank you, Dr. Freund. Can I just ask you, how long does this last? I mean, do you have any idea, like, what's the longest follow-up you have had on this?
So easily 10 or more years. I think it persists.
It
As long as the RPE is still there, well, I guess when the RPE goes, it will become even darker. But as far as I know, it's permanent. Yeah.
The other question I had was, is there a similar thing happening with the sub-RPE hemorrhage? Is there a...
So I don't think...
because there, the level of the blood is at a different level, so...
Yeah. I can't tell you that I've looked that much, so I don't want to just give a off the top of my head answer of whether you see this in sub-RPE hemorrhage. My guess is no. If I think of the patients like with aneurysmal type 1 that often get these large hemorrhagic PEDs, often if those resolve, the blood never gets above the RPE, those eyes can look completely normal afterwards, and I think if they had this big zones of hypo, I would have remembered that, but I should probably take a more careful look at that. But my guess is it has to be in the subretinal space.
What about PCV? Would you get a similar kind of a look in a PCV patient?
Excuse me?
PCV.
Yes, so if you have PCV, well, I call it aneurysmal type 1. I mean, subretinal hemorrhages is very common in that entity, and often the patients do better than our white AMD patients in terms of developing less subretinal fibrosis and RPE damage. So yes, you'd expect this is quite common in those patients because the blood resolves, but the RPE remains intact and it will have this hypoautofluorescent pattern. Yeah.
So you mean the origin of subretinal hemorrhage doesn't matter. The presence of the blood is what really matters, whether it's due to PCV or AMD or any other pathology.
Macroaneurysm will get the same thing. So presumably the iron is in some way interacting with the lipofuscin and changing its autophagy, but that remains to be proven. But we have a donor now, and Joshua Dunieff, who's at the University of Pennsylvania, all of his research relates to iron effects on AMD and degenerative diseases, and so in our donor who has this finding, we've sent the tissue and he's done iron stains that we have yet to have found time to actually analyze those specimens, so maybe that will give us some answer.
Any other questions from the audience? I think we'll go ahead with the next talk then.
Thank you, Dr. Freund. I call upon Dr. Gemmy Cheung to talk on incidence and risk factors for macular atrophy in an Asian population treated with anti-VEGF.
Thank you very much, Chairpersons, and it's my great pleasure and honor to be at the RISHI and VRSI again, and my sincere thanks to Professor Vishali and to VAS as well. So when I submitted this talk, it was particularly on macular atrophy, but since then the data for fibrosis has also come along, so I'm going to cover both topics in an Asian population. We've already heard a lot about all these factors this morning, and I'm going to share with you how we apply this in a clinical cohort. We have heard that the CAT study has now given us 5-year data on visual outcome. We know that at 5 years, the visual gain came back to pretty much about baseline. And very recently, Glenn Jeffy's group has published that looking at the macular morphological factors is useful to predict whether patients are going to have worse or better outcomes. Amongst the many factors, we know that associated with worse visual outcome are intraretinal fluid, subretinal hyperreflective material, fovea-involved GA fibrotic scar, abnormally thin or thick retina or larger CNV, and better visual acuity is associated with presence of subretinal fluid and sub-RPE fluid. We've discussed many of these features individually this morning, and we've just spoke about this a few moments ago, that in an Asian population, we have a significant proportion with PCV or type 1 aneurysmal type 1 neovascularization, and there are some reasons why we suspect that maybe the incidence of macular atrophy or fibrosis may be different. For example, patients tend to have a more hemorrhagic presentation. We here tend to give much fewer anti-VEGF compared to US or Australia, for example. We still use PDT in about a third of our patients, as you will see in a moment, and there tends to be less drusen background, and whether that's associated with macular atrophy development, all these are questions that we want to ask. So I have been very lucky to have the opportunity to work together with the Duke group led by Glenn and Dilraj, and we looked at this project to identify morphological features associated with 1-year visual outcome in an Asian cohort of clinical patients presenting with treatment-naive neovascular AMD. So the methods very quickly, the study population is a continuing cohort from our clinic, which has been going on for about 10 years. These are all treatment-naive neovascular AMD patients. We type them according to typical CNV or PCV. They all had standardized imaging, at least at baseline at month 12, and they all had FA and ICG amongst other imaging modalities. Treatment, however, was according to standard of care. So in terms of looking at the grading protocol, we were very lucky because we can borrow many of the experiences from the CAT study trial, and we had a few WebExes to look at some images from our Asian cohort, and we selected features that were relevant. And around the same time, this paper down here at the bottom has also been mentioned, is that around this time, the CAM study group has also recommended minimum imaging sets to grade macular atrophy. So we also incorporated the C-RORA into the OCT grading. So we came up with something like this. This is a full data set. A patient must have at least a color fundus photo, FAF, FA-ICGA SDOCT, which was done with EDI imaging mode. And this is an example of the list of features that we had to grade, which was actually quite labor intensive. So we divided up our labor. So in Singapore, we graded on fast imaging. So color funders, FA, ICG, and FAF. Whereas at Duke, they helped us grade all the SDOCT features, including if a feature is present, any quantitative measures as well. And mentioned, we use CRORA on OCT as a measure of atrophy. So in addition, as mentioned earlier on, for example, with SRAM, we know that these are SDOCT features, but the multiple features can actually give you this OCT finding, so that when we had to grade presence or absence of macular atrophy or fibrosis, we took into account the multimodality, and most of the time the agreement was quite good, about 70 to 80%, but when there was disagreement between different modalities, then all three of us, myself, Dilraj, and Glenn, will look at the full set of images together and grade the final presence or absence of these two specific features. So for example, I think we've gone through these. These are all eyes with SRAM, but they can be from different sources. The first one from blood. Second, when we look at the other modalities, there's a fibrosed CNV. The third case is mainly from exudation of fibrin from an area of activity, and final one is also an area of fibrosis. So once we've done all the grading, which was the very labor-intensive part, we performed a statistical analysis to look at incidence, risk factors, and also population attributable fraction when we look at each individual with multiple signs. So a patient could have fibrosis, could have fluid, could have blood. So which of those signs is the most important in determining the vision? So we had 93 eyes altogether. These are the baseline features. On average, 71 years old. And you can see that about the decimal point is 47% with typical CNV, 48% with PCV, and about 4% with RAP. Overall, this is a standard of care. Patients received on average 5 injections within the first year, and about a third of them had PDT as well. They presented with quite poor vision, as quite common, I think, reflective of our Asian population, but over a year, they improved by, on average, about 10 letters, and there was a significant reduction in the central retinal thickness as well. So these are the baseline morphological features, and here I have divided them according to typical CNV on that side and PCV on this side. I just want to highlight the 3 features with the asterisks here that, as expected, eyes with PCV tended to have very few eyes with typical type 2 CNV. They tended to have more eyes with choroidal vascular hyperpermeability and also fewer eyes with intraretinal fluid at baseline, but there was not much difference for all the other features. Now, what happens at month 12, you can see here in green, we see that for both lesion subtypes, there was significant reduction in subretinal fluid and subretinal hyperreflective material for both subtypes. In exchange, however, you can see that there was a significant increase in eyes showing fibrosis. For eyes with typical CNV, the proportion with increase in macular atrophy was not very much, but that was significant in eyes with PCV. And here you can see the prevalence of fibrosis and macular atrophy both at baseline and at month 12. So essentially, at month 12, we have about up to 40% of eyes showing fibrosis. And for macular atrophy, this is about 18%. In terms of the incidence overall, the incidence of macular atrophy is about 10%. I'll show you a little bit more details in a moment. Just to show, again, to illustrate the changes in subretinal hyperreflective material, in this case, this was completely resolved after 1 year. This was undefined SRAM at baseline. Another case, probably fibrin or exudation, completely resolved at month 12. This is different. This is a mixture of, you can see, blood from the other modalities and also some exudation at baseline. And at month 12, this consolidated into a lump of quite well-defined subretinal hyperreflective material here. When we look at the other modalities to see what was contributing to the SRAM, you can see that at month 12, most of the SRAM was due to fibrosis in green, whereas at baseline, this was due to a multitude of other lesions which can can resolve essentially what we've found. In terms of impact on visual acuity at month 12, patients with PCV had better visual prognosis. Those with poorer baseline had poor visual prognosis. That's to be expected. In terms of the morphology, we found that baseline fibrovascular PED and month 12 thicker retina, SHRM, and fibrosis were associated with poor visual prognosis. Now that is a multi-variable test, but it doesn't take into account the frequency of each sign. So for example, fibrovascular PED was significant, but only 14% of patients had this sign at month 12, whereas fibrosis, as I've mentioned earlier on, was actually very common. About 40% of patients had fibrosis, and therefore we looked at PAF, and we found that within this population of about 100 patients, really looking at the very last column here, that SHRM, down here you can see that with an odds ratio of 9 and above, can explain about 58% of the reason why patients had poor visual outcome of less than 2200, and fibrovascular PED to a lesser extent, explaining about 10%. I think I'm running out of time. We also looked very briefly at the risk factors of fibrosis and atrophy, but I don't think I have time to go into these, and I will just summarize. So I think we had a look at many, many features and risk factors, and I think the most important findings we found is that SHRM at month 12, and to a lesser extent at baseline, was really the most significant morphological factor associated with poor vision, and the prevalence of this is about 45%. SHRM alone is obviously an SD-OCT sign, and we find that at month 12, most of the SHRM was actually attributable to fibrosis. Whereas macular atrophy, it does happen in our Asian population, about 10% at baseline, increasing to about 17% at month 12, with an incidence of about 10%, but literally that was about less than 10 eyes in this population. So we were not able to show statistical significance in many of the risk factors we wanted to look at with macular atrophy. Thank you very much for your attention.
Thank you, Gemmy. Anybody would like to? Yes, Dr. Jose.
That was very, very interesting. Question for you. There were a lot, you had a lot of questions. And so then you have to look at the false discovery rate. Did you do a Benjamini-Huckberg or a Bonferroni to take that into consideration?
Currently, we have not. We just did the multivariable adjusted, and we also did the population attributive fraction. Yeah, thanks.
Dr. Cheung, just one question I had. In your analysis, PCV patients had more macular atrophy than CNVM, AMD?
About similar, yeah. About similar, about 40%, 30 to 40% at
PCV was not more. One of the slides I thought that MA was macular atrophy in the last, no?
Yes, was more in
was
PCV.
More in
that
PCV
was more because at baseline, PCV subgroup had less macular atrophy, whereas at month 12, the two groups had similar.
Similar atrophy.
Thank you. Would Prithvi Mruthyunjaya come up? He would be presenting on incorporating multicolor SLO imaging into your practice, replacing the clinical examination.
Thank you to the organizers for having me here at the meeting. It's lovely to be back in India and to be able to interact with friends, both old and new. We'll be talking about multicolor OCT and whether it can replace the clinical exam. And I'd like to acknowledge Henry Fang, Sumit Sharma, and Sanjay Asrani, who were my co-collaborators on this, and I have no financial interest in this material. So the complexities of our retinal practice, whether it's in this country or in others, is maybe similar. There's a heavy injection burden that can sometimes be overwhelming. And depending on your practice, it may be difficult or hard to examine every patient that walks in through the door if they're going to be getting injections. There's data that now confirms the efficacy of monthly treatment for patients getting injections, and we've become comfortable with having patients on a scheduled monthly routine pattern for injections, or having, say, 3 injections in a row and then getting reevaluated. And in some countries, you're not getting paid for the work that you're doing. So if you see a patient and examine them and then do the injection, you may not get reimbursed if you did that on separate visits. And if you obtained an OCT and color fundus photographs, there may be a reduction in the reimbursement that you receive for doing both of these tests at the same time. So here's a 75-year-old patient with neovascular AMD who's on a Q8-week injection cycle with bevacizumab. And here they've come for a planned injection in the right eye. Visual acuity is 20/80, and the patient has no new symptoms, and the OCT looks very stable. So looking at the OCT, the question is, do you inject? Well, probably, because you're planning to inject the patient anyways. Do you change the interval of the injection? Do you change the drug that's used? Or do you take the patient in for an examination? The truth is we're very comfortable in looking at the retina in cross-section. We know that that gives us information on retinal thickness, RPE irregularities, the presence or absence of fluid, and the presence of features in the choroid. But the OCT does not tell us necessarily about the coloration of what the fundus looks like, whether there is blood or not, lesions that may be present, and whether there's extensive areas of atrophy. Now, I will hold that nothing beats a good clinical exam, but even in these days, clinical exams can be time intensive, it could be subjective, and maybe it's becoming more of a lost art. Many of my trainees don't know what a macular contact lens is because they just haven't used one during their training. And it may or may not really impact your treatment decision. You might still inject the patient anyways. And OCT-based imaging helps decision-making because it's accurate, it's reproducible, it's repeatable, and it's clinically efficient and validated. So this same patient who came in for the injection, if you had a color photograph at the same time, you would notice that there was subretinal hemorrhage that was present, that the patient did not realize there was any change in their vision. So this becomes a branch point in your decision-making. You might then take the patient for an angiogram, examine them differently. You'd probably still inject them, but maybe you change the interval of their follow-up or the drug that's even being used. Ocular structures reflect each laser wavelength of light with variable intensity, whether you're looking at blue, green, or infrared that can penetrate through all the layers of the retina. We're all familiar now with pseudo-color imaging, but with the Optos wide field system as well as the NIDEC and the Zeiss Claris system. And now companies are coming up with combination systems that combine both the multicolor SLO image and the OCT together. So the Optos Monaco was just released, and the Heidelberg Spectralis using the multicolor mode has now been available that has 3 scanning lasers, an infrared, the green reflectance, and the blue reflectance in one system that comes together to give you a pseudo-color fundus image. And we were interested in looking at various characteristics of these Spectralis multicolor mode. So there have been studies that have been done previously. Usha Chakravarti's group looked at 105 eyes with AMD that had both color fundus photographs and multicolor imaging, and they found that there was a high sensitivity by the multicolor images for early and late stage AMD. Hemorrhage was seen better on the color fundus photographs, but atrophy borders were well defined on the multicolor. In another study here by Ben Musa and colleagues, they took 22 patients with geographic atrophy and underwent multimodal imaging and found that the fundus autofluorescence and multicolor imagings had the highest correlation between observers for both the extent and the size of the lesions as they were measured. Epiretinal membranes are another area of interest using this modality, and 2 groups have published on eyes with epiretinal membranes that were imaged with multimodal imaging, and it was found that surface folds and other delineations on the surface were seen best with multimodal imaging, while color fundus photographs sometimes failed to identify an epiretinal membrane in nearly 12% of patients. So if we look at multicolor OCT, it's a quick acquisition, about 5 seconds added to the acquisition time. It can be done non-mydriatically. You can view the separate channels individually, and you can get the simultaneous OCT, but again, it's not true color. A traditional color fundus photograph does require a bright flash of light. There's probably less artifacts, and the color is more akin to your clinical examination, but then you have to move the patient to the next machine, which takes time and it takes resource as well. So we've published on our study aims here to assess posterior segment findings on multicolor SLO imaging and correlating it to cross-sectional SD-OCT. And we wanted to quantify the agreement or disagreement between these imaging modalities. So we looked at 159 eyes of 96 consecutive patients that had both multicolor SLO imaging and SD-OCT on the Spectralis. And we looked at outcomes in terms of a positive and a negative predictive assessment to see how well the SD-OCT and the color fundus images may correlate. And what we did was divide the retina into several zones, so the outer retina and choroid, presence of fluid or blood within the retina itself, and then the retinal surface. So if we look at the choroid and outer retinal features, here's an example of a choroidal nevus seen on cross-sectional OCT. If we look at this in the infrared, we see the delineation of the lesion itself. We don't see the borders as well on the green and then on the blue reflectance, but come together with a multicolor, then we are able to identify the overall location of the lesion itself. If we look at this patient with a cross-sectional pigment epithelial detachment, looking at the various modalities with the multicolor showing the entire area, we can see that in this case, both the green and blue reflectance seems to outline that area of abnormality a little bit better. So we found that infrared reflectance identified most of the choroidal and outer retinal findings as well as multicolor, but pigment epithelial detachments, because of the elevation of the retina overlying it, was best seen again on blue, green, and multicolor. How about blood and fluid? So here's a patient with both subretinal and intraretinal fluid. On infrared, we barely see some abnormalities, but on green and blue reflectance, we can see these petaloid spaces that when we come together with the multicolor shows us a pretty good representation of the clinical examination. Again, this patient with subretinal hemorrhage that's not noticeable in the cross-sectional OCT. On the infrared imaging, we can see some area of darkness deep down, but the green, again, highlights the area of blood as well as the blue reflectance. So we found that for fluid and blood findings, intraretinal fluid was best seen with the blue, green, and multicolor modalities. Intraretinal hemorrhage and subretinal hemorrhage were detected most frequently with the multicolor and then in order by the green reflectance. But intraretinal and subretinal hemorrhages were not identified on the cross-sectional OCT alone because of the similarity in the reflectivity between the blood and the retina. So this was actually a way to enhance the examination. If we look at the inner retina, I think that being able to visualize epiretinal membranes is really one of the pluses of this modality. Here we can see an epiretinal membrane that's imaged with all of the channels, and the green and the blue really identifies the extent and the folds and even the surgical picking points if you're trying to plan surgery. So surface retinal pathology is more effectively detected on green and blue multicolor reflectance than on the infrared, and it's exceptional for monitoring. So if we look at this patient, we see some black lesions that were noticed on all of the 4 channels. When we look at those areas in cross-section, we're not seeing anything on the OCT. And this brings up a problem with artifacts. So up to 30% of images may have some artifact in this modality. And we feel that it's derived predominantly from the tear film with light scattering. And there's been a concordance by the study from Bill Freeman's group with dry eye in these patients. And artificial tears may improve the quality and re-imaging may be required. We identified 3 types of artifacts. One is called a spot artifact. The second is a wisp artifact, and the third is more of a net artifact. And 2 other artifacts that are related to lens status have also been reported. One is a ghost artifact seen in pseudophakic patients, and a hotspot artifact seen in patients with dense cataract. The good news is that if you identify that there is an artifact, sometimes having the patient blink or using artificial tears and repeating the scan may allow for the artifact to disappear. So in conclusion, multicolor SLO imaging effectively visualizes findings at various levels of the fundus. Simultaneous color and OCT imaging is efficient and it's additive to your clinical decision making, but it probably still does not replace a good clinical exam. Thank you.
Thank you, Dr. Prithvi, that finally you did conclude that the clinical exam is a must, because myself and my son keep having fights. He's an entrepreneur trying to develop a software, and he says, why do you need to see the patient? Can't you just treat the patient, over the internet, and they can, consult you?
It would be good to keep our jobs, wouldn't it? So, yeah. But so I think that there's probably some utility in certain clinical settings to have the ability to have both of these images taken together, whether it's for being able to transmit remotely. It may have an impact on things like diabetic screening and such. But in a busy clinic, it may be an alternative for some, but it's not perfect.
What is the specificity of this multimodal color imaging?
So we didn't look specifically at specificity we didn't have a true gold standard, but I don't think that's been well worked out yet. Jose?
Prithvi, question for you. So is there another artifact if there's an elevation of the retina, because then you get more scatter of the blue, and
Correct.
so it looks darker than what it really is?
So we were surprised in patients with pigment epithelial detachments that we thought we'd see it on the infrared because it was going to be more at the deeper layers. But when everything is elevated up, then you see this larger zone of blue and green scattering as well. But that's not necessarily a bad thing, Jose. So if I was just looking at that picture and I was trained to look at kind of the general change in the appearance of either the blue or the green, then that might cue me in to think that there is retinal elevation or thickening. So again, it may not make the diagnosis, but as the clinician, it might cue me into that I need to look at this more carefully. So it may be a tool to add, if not purely diagnostic. Thank you.
Thank you.
Thank you. We call our next speaker, Dr. Pulido Jose, on anomalous new vessels in optic nerve coloboma.
Thank you. Thank you so much for allowing me to be here. I've learned a lot myself, so I really have enjoyed all the talks today. So many are outside my area of expertise. These are my co-authors. I have no financial disclosure that's relevant to this. In 1969, Gass wrote that pits have leakage from the vessels around them, but by fluorescein angioscopy, he did not see it leak into the retina. And he showed the possible pathophysiology, and one of them was fluid coming from the vitreous, fluid coming from the subarachnoid space was another one that he saw as well. But it was interesting to me that he didn't talk at all in this histology that he had about these vessels right here in the choroid, right by the pit. So cilioretinal arteries are seen in about 16 of 25 cases of optic disc pits. And a fluorescein angiography study showed hyperfluorescence in the pit in 12 of 16 cases. And in particular, in all the cases in which both cilioretinal arteries emerged from the pit. Leakage from the disc was seen by other groups as well. In France, in 8 cases, there was hyperfluorescence at the pit, and they thought there might be a permeability problem in the blood outer retinal barrier. And the moment you start to look at these optic pit papers with this idea that Gass might have missed a little something right there in the choroid, right by the pit, you start seeing other cases where there was something right in the choroid by the pit as well. And so we went back and looked at our patients that had pits or colobomas, and we found anomalous vessels in almost every one of them, and if fluorescein was done, there was leakage in quite a few of them. Here's our first case, our test case, and there was a small coloboma inferior to the disc. In a lot of these cases, it was hard to tell whether it's a pit or a coloboma. Some people would call it a pit, some people called it a coloboma. But anyway, this patient had both, a coloboma and a pit, and you can see the cilioretinal artery coming out this way around the pit and going this way, and then you can see these other small vessels all around the pit as well. And you can see these vessels, this cilioretinal artery that goes around the pit, and you can see leakage within the pit. When you do ICG, you can see that there are actual vessels around the edge of where the pit is. And if you do OCTA, you can see that there's vessels in the pit and around the pit as well. And again, you can see down here you can see here, there's a very funny vessel right at the choroid pit area right there. And here's a case of a ciliary vessel that actually goes backwards here, and it comes down into the area of this pit. And to me, it was interesting. Here's some other vessels that arise almost from nowhere to come around this pit as well. And here is the corresponding fluorescein, and you can see that there's staining and leakage around the pit here. You can actually see vessels right here in the pit, right there. And again, over here, you can see it right there. Just another case. Here's a case from Italy, and you can see these very anomalous vessels all around the pit here. To me, that was interesting, and subsequently we looked at another case. This was an acquired pit. This was a patient that had a normal disc back in 2012 and developed glaucoma and developed an acquired pit, hard to see there, but you can more easily see it here, and you can see the choroidal vessels that go into it. And you can see the leakage in this acquired pit right there. Here is a coloboma, where everyone would say that this is a coloboma from Dr. Bandello. And again, you can see all these irregular vessels all around this coloboma. So when I first presented it, I was criticized, saying, well, you know, are you sure that these are the vessels that cause the fluid? I'm not saying that. What I'm saying is that these vessels have been disregarded, that the pit and/or coloboma is a embryologically abnormal disc. And why not believe that just like the pit, like the optic disc, didn't form properly, the vessels around it also didn't form properly. And it could be that it's a combination of problems, and sometimes the laser that's been done to treat the area around the disc may actually have been sufficient to close off some of these abnormal vessels. And when you think about the situation, it may be that there's fluid that's coming from the vitreous or the subarachnoid space, but the person is young enough being able to take care of it. But ultimately, with that and leakage from these other vessels, the person in the RPE or whatever can't take care of the leakage from these anomalous vessels, as well as the fluid that's emanating from other areas. So when you go back and look at the pits, your pits again, look not only at the pit, but also the funny vessels around it. Thank you.
Thank you, Dr. Jose. Any questions for Dr. Jose? We call on Dr. Adnan Tufail. He's going to present on macular ischemia and visual functions.
Great. So just like to thank our hosts again for being so charming, and in fact, Glenn, who I can't actually see, joined in on being charming since he got here, was inspired. This is him yesterday. So what I'm going to talk about is diabetic macular ischemia, which when I was a resident, I always asked questions about, and nobody really gave me an answer, is why macular ischemia drops vision when the fovea itself, the photoreceptors, are going to have a choroidal circulation perfusing it just anatomically. And the reason we looked into it more is I was part a few years ago of an ongoing project to look at endothelial progenitor cells to repair or look at the potential to repair diabetic retinopathy. Most of the work I'm presenting is from our then PhD student, Dawn Sim. So we were interested in it for a number of reasons, primarily initially because we were looking at when we would use a cell therapy to repair ischemic retinal vessels, but there are other questions about why would it drop vision in your foveal function and outcomes in DMO treatment. And the conventional wisdom about macular ischemia was the features were disrupted foveal avascular zone and some loss of the perifoveal and non-contiguous areas. And there was a grading system from the ETRS that is quite complex, and it took us a little while to actually track down the standard photos to be able to understand what the ETRS grading system was. And partly because fluorescein is invasive, that we don't have serial fluoresceins to do it. So large prospective studies don't have good data capture of this cohort of patients. So as I mentioned, we have this very complicated grading system, the ETRS grading system, and many of the longitudinal studies probably excluded patients with bad macular ischemia, even though it's not explicitly stated in its entry criteria. So what do we know about macular ischemia from the ETRS study? So they had over 1,200 eyes in the ETRS study, but there's quite a large attrition rate, and only a few cases had what was graded by that system as severe diabetic macular ischemia. And over the long term, diabetic macular ischemia, DMI, is known to progress, but it wasn't well characterized, and is known to be a cause of visual disability. And if you look at the literature, until recently, it was generally looking at different ways of measuring the foveal avascular zone. We had some very nice talks about that earlier today. So what we don't really know is the prevalence of it. We have less attention due to the lack of treatment options for macular ischemia, and we don't know, and because of the lack of fluorescein, although now with angio-CT, hopefully you have much better longitudinal data. So we've heard a lot about what normal or abnormal foveal avascular zone is earlier. This is the ETRS grading system. It's actually very complicated. So there's a central subfield, and I'm going to just go through that. And then there are inner and outer circles with different standard photographs of capillary dropouts. It's quite a complex grading system. I'm not sure of the publication on the repeatability of this. So this is what you do for the FAZ. You outline it, and so it's questionable, it's slightly irregular, mild, less than half the circumference is destroyed, so on and so forth. So I felt we need to do better than this. And so what we thought we'd do is, a few years ago, we looked at all our consecutive patients having fluorescein angiography in a tertiary referral diabetic clinic at Moorfields. There were 767 consecutive patients with type 2 diabetes. And we had a priori hypothesis, because I thought, well, yes, if the FAZ gets very large, it would drop your vision, but why would that drop your foveal function? Because the foveal photoreceptors have to transmit their function to the optic nerve, and the way they do that is through the papillomacular bundle. So is it that ischemia of the papillomacular bundle drives dysfunction? So we had an a priori hypothesis, but we actually wanted to test the enlargement of the FAZ and non-contiguous areas of ischemia and their location and whether that affected vision. So we looked at that in relationship to vision, the size of the FAZ and the location of the ischemia, and also got some prevalence data on a tertiary referral diabetic clinic. So almost 20% of patients were moderate to ischemic on the ETRS diabetic ischemia grading system. So it just gives you an example of an image here with non-contiguous temporal ischemia and an enlarged irregular FAZ, and then here ischemia of the papillomacular bundle. And in this immunostaining, the red outlines the papillomacular bundle. This is some image from Marcus Frutinger's work. And then the bottom shows the ischemic area affecting the papillomacular bundle. So we did some clever statistics called quantile regression to look at relationships between different enlargement areas and different functions. So quantile regression is the way of looking at complex relationships. So we know when we age, we get taller. But once we are post-adolescence, we stop growing. But there is a relationship with age and height up to a certain point. If we look at little quantiles of that data, we can look at relationships that may not be contiguous throughout the whole extent of the data set. So we looked at quantile regression and showed that independent of foveal avascular zone size, papillomacular bundle ischemia affected visual acuity. So it makes biologic sense, and we've shown it in this consecutive series of patients. We also looked longitudinally in patients who had severe DMI on the ETRS grading system were more likely to enlarge their FAZ over time. And this has clinical importance, as we know from RISE and RIDE. If you have more macular ischemia, you're more likely to progress to proliferative diabetic retinopathy despite anti-VEGF. And in collaboration with VAS and others, we looked at structural changes as well and showed that we have, with diabetic macular ischemia, you have inner retinal loss, but also loss of thickening of Haller's layer, which was slightly counterintuitive. We also found some other associations that with more severe macular ischemia, you are more likely to get arteriolar narrowing, but no venular change, which again was unusual because we're used to seeing dilated venules as you have assumed higher VEGF levels in the vitreous with more severe ischemia. But we actually found with this semi-quantitative tool that actually the arterioles were narrowed. So on this consecutive series of fluorescein angiography, we've shown that papillomacular bundle ischemia, independent of enlarged foveal avascular zone, and you need to get your foveal avascular zone quite large, so presumably you have to knock off your papillomacular bundle fibers with enlarged avascular zone, or have papillomacular bundle ischemia that's non-contiguous to affect your visual acuity. But obviously fluoresceins are invasive, and then we did some further work to correlate this with angio-CT. So I think this is a really great start on this work, and hopefully we can validate this on further longitudinal data sets. Because I think it's quite important in visual outcomes in clinical trials, as well as our potential stem cell work in the future. So in conclusion, we've mentioned about how prevalent macular ischemia is in a tertiary referral clinic. About 15 to 20% will have moderate to severe ischemia. It is associated with more severe states of retinopathy grade, and it progresses more the more severe your ischemic retinopathy grade at baseline is. And papillomacular bundle ischemia, independent of enlarged FAZ, drives visual loss. Thank you for your attention.
Thank you, Dr. Tufail. So I think now that we have OCTA, we can probably do the study over a larger number of population, and probably you can get more correlation or...
I think the data sets already exist, and I'd love somebody who runs a reading center to donate or regrade a data set so we can validate this in an independent data set. It'd be great.
I wasn't coming up.
Oh, I thought you were volunteering.
Any questions for Dr. Tufail from the audience?
Okay, so if there are not further questions, thank you very much for chairing that session. You know, we had a couple of, as if you noticed, we had a couple of people who, I know Andre Romano was ill just before he was about to board his flight, so he couldn't be here for that session. And B.Kuppermann, I think his flight is delayed. So we do have a special presentation, though. As you know, at this break, we want everyone to head to the poolside first for a picture. But before we're ready for that, we want to tell you about RISHI 4. Hopefully you're enjoying this meeting, which will be in September 2020. But Manisha Agarwal and Sarah Bluthra have kindly agreed to organize this meeting and to tell you about the venue and attract you to come. Sarab is going to give you a short presentation, and then we'll go to our break for the picture.
Thank you, Dr. Sada and Dr. Vishali, for this opportunity. So the proposed venue for 2020 RISHI is Mussoorie. So some of the past meetings that we have done is a Vitreoretinal Society meeting in 2007, and a few international faculty, Dr. Kuppermann, Dr. Gaurav Shah, who are in this meeting also were there. And the oration was given by Dr. Kuppermann, and these are some of the photographs from that meeting and some of the entertainment photographs. Then we also had some Sight Savers International ROP workshop, which was done by Dr. Azad. And then we had the North Zone Ophthalmic Society meeting with Dr. Biswas, Dr. Lingam Gopal here, Professor Pandar, Professor Jagatram. So we've had meetings in the past, and recently in 2013, we had the Uveitis Society of India meeting. Again, international faculty was there. So Mussoorie is also known as the Queen of Hills. And this is a venue, a proposed venue for the RISHI 2020 meeting. It's on a hilltop. So it's about 9 acres of lush green area on a hilltop, and it's a 5-star accommodation. And some of the tourist attractions in Mussoorie, we have the Lal Tibba, the Gun Hill, Kempty Falls. Also Rishikesh, the birthplace of yoga, is just about 20 kilometers from Mussoorie. So these are some of the attractions and some photographs. You can do river rafting, you can go to the Rajaji National Park. Oli is also not too far, where you can do skiing. And there's Ananda in the Himalayas. So this is a short video which I'll leave you with. So this is for the venue of the meeting, the proposed venue. This is JP in Mussoorie.
The dates are announced? The dates?
The tentative dates are, I think, September 26th and 27th, 2020. The most amazing part is the terrace from which you can see the entire valley. Thank you.
Shall we head to the, no. Oh, I'm sorry.
Yes. So for the photographs, all of us can actually head. There's a staircase here, right next to the restrooms on the first floor by the pool side. So we can just, we can go right now, and we can come back here to start the next session at 3:30. Thank you.